Good evening. Thanks for having me over to talk. Today my presentation is going to be on knee health and a little bit more. I like to use these presentations also as a way to learn something myself about the current, something new, something fascinating. But been talking with this program quite a few years over the years, and it's always interesting to see. Starts out with a pretty broad audience, and then it whittles down to the most committed diehard. So, but thanks for having me. I'm a physical therapist by trade, and I've been doing this role for about 20 years. We recently moved our clinic from about a block or two down the way up to next door. It's been a wonderful move for us. Helps us get a little more day-to-day interaction with the crowd here. We also have a satellite clinic in Conneaut, in Jefferson, and soon to be Geneva. And we also have services on the third floor of the hospital, so PTOT speech. We serve patients who are inpatients who might have had surgery or might have had something that puts them in the hospital, and they're having struggles with their mobility afterwards, so we're consulted in to try to help those. But that's me. So today, we'll talk a little bit about functional anatomy. I'll probably get way too in depth, so just somebody wave their hands if I'm over talking the point. I'm going to show you a couple video examples of faulty movement patterns, talk about how we address knee pain, some of the things I like to do, and maybe some of the things that I don't tend to go to first. Talk about running, some controversy on is running healthy, is running not healthy, and how there isn't really a consensus in some of the professions. We'll put the study results into action, and I'll just give you my thoughts on some underrated exercises. Some of them are going to be difficult, some are going to be easy, and anywhere in between. So starting out, just the functional anatomy. So upper leg, just looking at the musculature. The quad is made up of four muscles here. You have the rectus femoris, and then you have the other vastus muscles. These are extensors of the knee. They'll straighten your knee when they're working. The rectus will also flex your hip. When the foot's planted on the ground, these will do the squat or contribute to the squat maneuver that you guys just did. If you jump down to the lower leg, the main muscle I'll talk about, the two main muscles, anterior tibialis and the gastroc. So anterior tibialis, the muscle that's going to pull off your foot. That muscle is involved, like if you're walking or running and you hear a foot slap, so that muscle's probably weak or having some trouble there. So, and then the gastroc is plantar flexor, is going to point your foot down. You also have muscles on the outside, but we're not really going to talk about them for the purpose of today. So if you go to the back side, there's the gastroc, lateral head, so lateral outside, medial inside. And if you peel away the gastroc, you see the soleus is underneath. So the gastroc attaches up at the back of the femur, the long leg bone. The soleus is a little bit lower. So they work similar. They both point your toes, but if you bend your knees and lift up, that's more the soleus. So talk about the soleus a little bit more in a couple studies. Really important muscle group for knee health. If you jump up to the back of the leg, these are the hamstring group, biceps femoris, semimembranosus, tendinosus. These flex your knee, these bend your knee backwards. They'll do a little bit of what we call external rotation based on where their attachments are. So they'll externally rotate your hip a little bit, and they'll contribute to hip extension. If you come up a little bit higher, glute max, glute medius, this muscle, I'm going to talk about this muscle a lot in the presentation, so it's important. Glute medius is really critical in not only controlling what action happens at the femur, but the knee, but also in your gait. Sometimes you'll see folks with a kind of a waddling gait, and we call it a Trendelenburg gait. So if you peel these muscles away, you get these deeper muscles in here, and you can see their attachment sites. The yellow there is the sciatic nerve, so you can see it kind of dives in underneath that muscle. So sometimes spasms or trouble in that muscle group can lead to referred leg pain. So this is what we're talking about, that gluteus medius muscle. Got a couple videos that I'll show you here, but when that muscle is strong and that hip joint is healthy, think of that muscle like it's connecting the two dots, so that ilium is the bone, that's the attachment or the insertion the attachment site, and then it inserts down at the femur. So when it's contracting strong, it's going to keep short. So if it's not strong, you're going to see more of that. So if you drop the plumb line down your spine, right down the middle, and then you drop the plumb line there, you can see what ends up happening when this muscle is weak is that knee is effectively more towards your midline. So we call that valgus. We're going to talk about that a little bit. But also the key point is the pelvis is level in a strong muscle. And if it's weak, anytime you're on stance phase, so she or he is standing on the right foot, in a strong situation, your pelvis is going to stay level. In a weak situation, your pelvis is going to drop. So we'll see that sometimes. Sometimes it's a weak muscle, and sometimes it's a bad hip joint. So if we show the muscle in action, I'm hoping this will back up. I'll let you do that. There we go. So if we click the video, this is a runner. So what I want you to look at is just kind of the level of the hips. And then when she hits the ground, the level kind of bottoms out. She hits the ground on the left foot. The opposite happens. See that kind of that angle, that steep angle? So we don't know whether this runner's just started or whether she's been running for a half an hour, but we would call that, some level of hip drop. And we would want to try to see, is that an endurance problem? Is that a strength problem? She might not have any pain. She might be doing just fine. But if you see that in somebody who starts out just fine and then 10, 20 minutes in, you start to see that there's very likely going to be an incidence of knee pain, some different symptoms there. So the ability of that muscle to hold sometimes will fade after 5, 10, 15, 20 minutes. It just doesn't have the endurance. So critical, and it plays a role in knee health. It's far away from the knee, so if a patient's coming in with knee pain, we have to look at the hip, we have to look downstream at the foot and ankle. So if we look at this other one, so if we have this person, what might we do? This is just a quick video, assuming they're doing okay. This is one of the many things we might do. But again, you can see him holding the hip high. This is just a hip hike exercise. And he's working the left glute med there to try to elevate the pelvis on the right. It's kind of a tough one to do. So the ideal is more on the left. I'm not sure quite the point that they were going for, but just to show the hip hike. So that's good there. All right. So this illustrates the normal alignment. So you drop a plumb line. That's pretty normal. You might think of that as bow-legged or varus deformity. You see right there, there's a little bit of breakdown at that inside part of the knee. Valgus is what we're going to be talking about more today and kind of what we're alluding to on the running slide. So think knock knee or knees coming toward the midline. This is RG3 or Robert Griffin III. I've used this picture in past presentations, but I like it because it illustrates a lot. He's an elite athlete, so he's not a strength issue. You really don't think it's a strength issue, but this was his combine. These are snapshots from his combine. I think he was doing broad jump, but we see a faulty knee pattern here. Here's fine, and then he drops down to develop power, and you can see his knees are almost touching. So the biomechanics folks use the combine in many respects to predict injury rates. And there is a link between these faulty mechanics and higher incidence of ACL. Now, it might have been something to do with like a 300-pounder tackling you all the time, or it could have been this or a little bit of both. But he did end up later tearing his ACL. I don't know if it was with Washington, but I think he spent a stint with the Browns, real short, but his career was short. He was a very athletic individual, shortened his career through injury. But if we look at this video, I'm going to click on that one. Just a real short video, and it's going to be 6 seconds.
Go ahead.
I don't need sound. So if you click that sound so we can kill that there. And then do it again.
The first exercise we're going to have a look at is a single leg.
Yeah, go ahead.
All right. So I don't know if you can see what she's doing, but in and then blow it up to full screen. Right there. Sorry, I put you on the spot. All right. So if you pause it, she has 3 episodes where she does that. First on the takeoff. Oh. Technically, it's just going on to the next video. So takeoff, land again. So her knees come together. So if you're not watching it happens quick. So a lot of times we'll try to do a slow-mo video. Say, all right, let's look at what's happening there. So this young athlete, women are a little bit more susceptible to this. So high school female athletes have a higher incidence of ACL tear. Some of that's hormonal. Some of that's angular, wider hips. So a slightly higher, what we call Q angle, or that valgus angle. So you see the knees kind of kiss together each time. So that's a problem. In these athletes, we would train that out of them if we catch them. You still see folks using that. Okay. You can go to the second one. This is a gentleman who has the same thing, except he's good at landing, but he's bad at the takeoff. So watch on the takeoff. Knees kiss together real fast, but he's good at landing. So he's probably gone through some level of training to say, hey, stop doing that pattern. So what we would do for that is a couple things. Put bands around their knees, put bands around their ankles, have them do these drills to try to prevent that. So just a quick, when he lands, he's fine, but the takeoff, boom, right there. So that's the faulty pattern. All right, next video. So what does good look like? Ohio State was doing some research on this phenomenon, but she's doing well. Either she had an issue and she fixed it, or she's just an athletic person, but the knees do not come together. So her hips are doing their job, her foot and ankles doing the job, and she's not subjecting her ACL or her knee to those stressors. Okay. Nope. I started moving it on there. Okay, you can escape out of that. Go back to the press. Okay, good. All right, so knee valgus strategies. I have a couple other videos that would show that, but if we do this one, we'll just watch it once or twice. So this might be a strategy we'll use. We want him to oppose that knee from coming in. We don't want that knee coming in, so we want him to have to resist against it while he's doing something functional. Right now he's doing a single leg squat. We might have him start with double leg, but just to try to drill that pattern home. And then as we go, we want to make sure that he puts that into action. So if he's a runner, or if he's a jumper, that sort of thing. Okay, next one. This is just another little simple cue that you might use. He'll show you the wrong form of lunge. You see that knee dive across? So that's the faulty movement. Don't like that. Do enough of those, he's going to have knee pain. This will just be a simple cue to push the foam roller lateral and kind of drop into a squat so you can immediately control it. So something like that, immediate feedback. You can show the cause and effect real easy. We'll do an iPad before or after for the patients. And it's dramatic usually, and it doesn't take long because sometimes it's just the way you move. It's motor planning. It's not necessarily always a strength issue. Good. This one, this shows a pretty good cave in, not on the way down on our squat, but on the way up. Boom. You see a lot with weightlifters. So yeah, you're exactly right. That's like yuck. So we're going to work that in lighter loads. We're going to just try to drill home. You want those knees stacked. Sometimes it's a hip problem. Sometimes it's a foot problem. So these pronators, people with flat feet, can dive in. That can force the knees in. So this might be a cue that we'd use, either a band around the knee, but sometimes it works better with the band around the ankle. I'm going to make sure they're in good footwear. And a lot of times it's just people are trying to do too much too soon. Like they jumped into the weight training. And even bodyweight squat, you can have this pattern. You can see, good on the way down, but probably overdoing it. So there's the foot angle. Good. So what do we do about it? I was talking about that before, but another one is just those bands, those elastic bands. I love them. We use them a lot. But just loop them around the ankle and call it a monster walk. Just on either sideways, forward, back. And if you've ever done these, you'll have burning up at your hips. Be on fire if you do enough of them. So 25 feet, 2-3 laps in the gym, and then they'll be ready to be done with that exercise. So we'll have them go backwards, we'll have them go sideways as far as just different things that we'll throw at the patient. Good. And you don't have to play the last one. The last one is just a lateral monster walk, same thing. Good. Okay. So addressing knee pain. This is kind of like what I don't do. It's not the first approach because I'll show you a few slides with the evidence. There's not real strong evidence for these things. There's weak evidence, and the other tagline will be, it all is going to depend on what's driving the problem. Sometimes these things work great. So bracing, I am not a huge fan of bracing. Do braces have their place? Yes. There's all different types of braces. There's an ACL brace, somebody coming off of a surgery and they want to protect that graft. That can be important. There's medial unloaders, so there's braces, like if someone is having that bow-legged deformity and they are breaking down on the inside, the medial unloader can kind of drive a little bit of a force there, so it takes them a little bit more toward neutral. That can have its place. Talofemoral bracing, so the braces that have like the cutout for the knee, like a sleeve, sometimes that's just feels good to have a sleeve on it, warm joint. I can see the point for that. But I'm not a real big fan of bracing if you can work your way away from it. Sometimes in the beginning, great, but usually we try to get most folks off the brace if that's how they started, if they were there before the injury. Taping, same thing. You've seen the Olympic athletes, the kinesio taped all over them. I think last Olympics I saw a lot of cupping marks on people. But as far as the taping, there's some evidence that it can maybe block some of the pain fibers, change the way you feel or sense the pain. So I won't say it's not effective, but usually in supplement. If you're taping, you want to be doing something else. Sometimes you're taping to try to help a muscle group while you're working the muscle group to get stronger. Passive modalities, heat, ice, electric stim, yeah, they have their place, but interesting, the guy that came out with rest ice, compression elevation, has kind of since walked back some of his initial takes. There's now kind of a shift in science that says, well, maybe that inflammation when you have an injury is supposed to be there. And you're supposed to. So it's funny, you wait long enough in science and in our field, and sometimes like the common held mandate for us changes over the years. So, but you might sound like a loon if you introduce the opposing idea at the time. Static stretching. This one's a pet peeve of mine. Static stretching, it depends what you're aiming for. If you're trying to improve flexibility of joint, improve joint range of motion, great, go for it. If you're trying to improve your athletic performance, you don't want a static stretch. The evidence says you're going to be weaker, so your jump performance is lower.
Sorry, what do you mean by static stretching?
So static, good question. So static stretching would be if I'm stretching my hamstring and I'm going to spend 30 to 60 seconds just stretching it. So as opposed to, so the opposite would be like a dynamic stretch, which might be kind of what you guys were doing a little bit, just kind of getting the blood flow, getting things moving, spending shorter time. So I liken it to like, if you ever see an animal stretch, dog stretch, yeah, they'll get down there and they'll do that, but they don't spend 60 seconds there doing that. They're going to shift, they're going to do all sorts of different things. Not to say that we need to take our cues from them, but the study will show you that it decreases force output. So it is, if it's post-exercise and you're done your athletic event, you're not trying to compete at the best, great, go for it. It's not going to harm it. And then strict avoidance of functional movement due to pain. So we're meant to squat, we're meant to move, we're meant to bend, and those movements aren't what causes breakdown. It's probably our loss of those movements over time and our less activity that gets us into trouble, more so than squatting. So usually if someone comes in and they're avoiding certain things, we'll use that strategy in the beginning to try to settle them down. But ultimately, if they got to bend down for their job or do the laundry or get down in the dishwasher, you name it, we want to try to reintroduce those movements. So that's kind of not what I do first. So the preferred, as we alluded to, you want to try to find the symptom source. You want to see what makes the patient better or worse. Look upstream, look downstream. So if it's a knee problem, look at the hip, look at the core, make sure everything's working. Look for symmetry, see if they're stronger on one side, weaker on the other. Modify the activity, scale back what you're doing problematically. Check the footwear, make sure it's a match. Sometimes you go to a store and there's motion control shoes. Well, some people are supinators, high arches. Some people are pronators, real flat foot. You want to make sure there's a match there. Sometimes you're in the shoe that's going to work for somebody who doesn't have your structure. So we look at if they're doing an exercise program and that's what hurt them, we want to check the form. Fixed volume problems, sometimes athletes don't want to stop doing the thing that they're doing that brought them there in the first place. You've got to tone them down and say, hey, it's okay. Sometimes the body needs a day or two to rest, or a week or two to rest. The last two statements are really what we do in a nutshell as therapists is introduce adaptive stresses to drive the body to change over time. So we got to be expert at scaling it. Like if we want to lunge and it hurts to just bend that far, then we got to figure out how do we progress that safely so that we can make the body do its thing. We're going to scale it so that the structures can adapt. So what's the literature said? I talked a little bit about it. And I'll try not to read all these. I highlighted some of the key statements. Knee taping as an adjunct to traditional exercise therapy doesn't really support it in isolation. So if you're taping, do something with the taping, strengthen the muscle with it. Sensory effects associated with short-term taping may be sufficient enough to modify knee pain acutely by really just changing the way you perceive pain. So again, there might be a place for kinesio. I think some of it's placebo, but I think there's some of it that goes a little bit beyond that. Knee orthoses, iffy, weak evidence for patellofemoral pain syndrome. I always struggled with these braces because the patients will come in and they have them on, and there's one called a J brace, and it's just cranking on the kneecap trying to pull it inward. And most of the time people are just complaining that it was uncomfortable and awkward. So I struggled early on in my career with recommending these because I was like, man, I don't know. I didn't see people that were amazed with them. Every once in a while, someone would do great with it. Static stretching. So this is what I was talking about. Muscle force decreased for 30 minutes after stretching. So consider it before you go into activity. So I always look at sports teams that spend a ton of time stretching pre-activity. I'm like, oh man, if you're a track star, or if you're a high jumper, or, you want to be a fast football from end zone to end zone, you might not want to do that. Another study, single static stretch resulted in 30% viscoelastic stress relaxation. So the stiff tendon unit or the muscle tendon unit, a tendon stores its potential energy by way of being stiff. You don't want a tendon super stretchy because when that foot hits the ground and it stretches, you want a spring. You don't want viscoelastic. So long-term stretching increased joint motion, but it was usually more or less the patient tolerated the stretching better. So within an hour, it returns to baseline. So you don't want to do it right before your athletic activity. Do your sport and then come back an hour later, and it's okay. Kind of defeated the purpose. And then this last one is just the triple hop test. Your knee torque is reduced. So again, the dynamic group or the no stretching group did not experience the same changes. So just food for thought. Okay, moving into a couple other studies. These were iliotibial band syndrome. So the iliotibial band is this tough band of tissue on the outside of the hip, kind of runs down from the knee to the hip. It is stretched by way of moving across. But it is typically a tight band. There's a lot of debate as to whether stretching it is helpful. These studies kind of pointed towards the development of that abduction, that knee valgus movement. This one was after 30 minutes of running, these runners were showing more of that valgus tracking, and they incidentally had the iliotibial syndrome type pain there. So that what they found was they were weak in the hip. Now, I don't know if they went on to study whether you strengthened it, but that's typically what we're going to do. If we see that pattern set up after 20, 30 minutes of running and they didn't start with it, we're going to go after trying to strengthen it. So sometimes that pain is a result of tightness, but other times it's weakness, and that lack of control comes from that. I get a lot of studies or a lot of questions about, because the research pointing to is arthroscopy or surgery effective for meniscal tear. And again, it depends. This looked at kind of the 2-year, I think this is the one that I'm talking about. Yeah, 2-year follow-up. They kind of said, all right, what's the surgery group look like versus those that just went the exercise route? And the groups look really similar to outcomes. So sometimes when you have a meniscus tear, you think, oh, I gotta get surgery. It depends. If you don't have evidence for a lot of advanced arthritis and it's not poking you in that knee just right, it's limiting your function, some of these can heal, or you can get through to the other side without it. Not against surgery. Surgery absolutely has its place, and if it's tearing up that joint, then it's a problem. But this would be the meniscus, like the medial meniscus, so the inside part of the knee. The outside of the knee, inside of the knee. I don't know if you can see that model, but those meniscus are really your shock absorbers and cushions. The lateral or the outside, so the medial would be on the inside of the knee, the lateral would be on the outside of the knee. A little bit more of a mobile group. So kind of like a crescent moon or a half moon. And if they tear, they can tear in multiple different places, and there's some thought as to, depends on where the tear is and how the circulation there is, as to whether that's going to be something you heal. That there's the ACL, and that's your PCL, just for locating those. So another group looked at just arthroscopy, and then arthroscopy with exercise, and the arthroscopy with exercise afterwards was doing better. It obviously helped thigh strength more so than just the surgery. So every once in a while we'll see, it tends to be just practice pattern. Some surgeons will prescribe therapy afterwards for just a simple meniscectomy, others won't. We recommend that it does happen based on the research, but also sometimes we can find other form flaws, like, hey, you're weak up in the hip, you're weak there, you should do these too to try to support it, prevent that from happening again. This reviewed studies that found strong support. If you have knee arthritis, you should strengthen your hips. So those other muscles. Again, far away, far upstream, but definitely contributing. Busy slide, I apologize, but I'm kind of geeking out again. But gastrocs, there's your soleus muscle, there's your glute medius, and then your hamstrings. This is just a quick roadmap to how to help your ACL. Whether you've had an ACL tear and you've come back from rehab, or you thought you sprained it, these are the 3 muscles that have shown the most support. And what they do, the hamstring and the soleus, because of the back of the leg, so the back of the leg, they insert at the tibia and the back of the lower leg bone. They provide a posterior force. So when they contract, those muscles contract, they pull the knee or the tibia, so the lower leg bone, backwards. So they create that. What happens with an ACL tear is a forward translation. So they're going to oppose that. So if I do a jump stop and I'm an athlete and I tore my ACL, your tibia has come forward on your femur. Okay, that's the main mechanism. The second mechanism is a hyperextension moment that can tear that ACL. The third is rotational, and kind of the fourth, you can have a valgus force that tears that. So think of somebody hitting you on the outside of the knee. So if folks with knee pain are weak in these muscles, like that gal that jumped off and was doing the knee knock thing, we would say, okay, we want to strengthen these particular muscle groups to reduce their risk. The gluteus medius, that one up the hip, consistently shown to oppose that knee valgus more than any other muscle. Just another 2 studies on knee valgus, potential risk factor for non-contact ACL. So there's the research behind it. And those studies have been going on for years. They've introduced some preventative programs and have found success in high schools and collegiate athletes. And then this is just kind of your precursor. Findings suggest that women with patellofemoral pain present greater dynamic knee valgus and hip muscle weakness. So there's a thought that patellofemoral pain, that knee achiness and that pattern, is that your early warning sign that they're going to progress into an ACL injury? There's some thought. All right, so this is a myth that we got trained in when I was in college. I love my education, but as with any other science, things progress. They really recommended parallel squats and don't go deeper because you'll hurt your knees. And about 12 years later, they kind of said, whoops, there's really not a lot of strong evidence for that. Some of it's just lifestyle. Now, if someone comes in and they already hurt, I wouldn't have them do the deep squat. We have to look, do they have the ankle mobility? Do they have the hip mobility? Can they keep their spine straight? And can their knee tolerate that range of motion? But in an uninjured state, a healthy state, contrary to commonly voiced concern, deep squats do not contribute increased risk of injury to passive tissues. And then here's that adaptive piece. The meniscus and cartilage, ligaments and bones are susceptible to anabolic, metabolic processes, and structural adaptations in response to increased activity. So if your goal is to be able to squat down, pick up a laundry basket, do those things, you probably shouldn't avoid it strictly. You should probably scale into it a little bit. All right, the perceptions. So this is just on running, kind of compared the public to healthcare providers and their opinions on health of running. So more healthcare providers perceive running as healthy for knees when compared to the public. But that said, 29% of the public and 13% of healthcare providers think that it increases your risk of developing knee osteoarthritis. So there's no consensus. Long distances, almost half of the public and healthcare thinks that causes arthritis. And on hard surfaces, more than half of the public thinks that that's problematic. So what does the evidence say? It's not possible to determine the role of running in knee osteoarthritis. So low quality evidence suggests no association and a negative association. This group found more knee pain in the non-runner group. One study found higher risk of knee osteoarthritis progressing to total knee replacement among non-runners. So I don't think running is the problem. I think probably running and then stopping and then not being consistent with it is probably more the problem. Or starting too fast or injuring yourself and then not ever healing that. So short-term running is not associated with it. The one study found osteophytes in what are the little bone spurs in certain areas of the knees in the runners, but it wasn't associated with necessarily a problem. And what do I think those? I think those are adaptations. Your body's like, oh, you're giving me more force. I better build up this bone in response to that. So talk about fatigue, increased contact time and strength deficits in runners. The study looked at lower leg pain. People with exercise-related lower leg pain exhibited longer contact time and decreased stride length during running, as well as strength deficits. So this kind of ties into the next slide too, where if you're running, you've probably heard the advice of land softly, or even jogging, land softly. Well, it's going to decrease your joint stresses. And as soon as you lose the ability to do that, as soon as you kind of are clomping down the road and you hear that and you can't control it anymore, it's probably time to stop because your joint forces are going up, your muscles have lost the ability to absorb that force. So you're probably pushing your endurance limits there. So you can train that, but you should probably listen to that. So the next one was just this AI model was pretty successful at predicting your ground reaction forces based on how loud you were. So it makes sense, but it's just validates the theory of, hey, be soft when you run, be soft when you land. Jumpers, same thing. We'll tell them, hey, be real quiet. Be as quiet as you can, and then you know you're not absorbing that. Or you are absorbing the force instead of giving it to your skeletal system. All right, effects of anti-pronation shoes. Helpful for overpronators. Reduced peak torque, basically. So your joints weren't subject to as much when you matched your footwear with the right shoes. Another one, motion control shoes prevented fatigue-related increase in loading. Cushioned shoes. I'm not endorsing any particular shoes, but I see a lot of these Hocus around. And I'm not saying these are the only cushioned shoes, but they did conclude some benefit for folks with osteoarthritis. So hard surfaces, you have arthritis, concrete surfaces, those hard surfaces are working all day. They're tough. We have a lot of beach, like 3 miles north of us. Go use it. It's very good for building up the strength in your foot, strengthen the calf, and improve frontal plane stability. This is for runners, but here's that gluteus medius muscle again. So if you want to rehab, lower impact, slower speeds, but sand is the way, or is a way. And then one more. The training group, but not the control group, resulted in lower peak impact forces. And these are just folks who trained on sand. So sometimes we'll get folks in the water. We'll have them run there. We'll get them on sand, on stable surfaces, practice different surfaces. So doing good on time. These are the last two slides. I just threw together some of the exercises that I like. They're not necessarily all lower body, but maybe some things that you haven't seen. So go ahead and click. So squats, you guys are doing the squats. King of the exercises, favorite exercise.
You can go back.
If you want a pound for pound, most efficient exercise for building muscle mass, squat is it. So this is anterior tibialis raises. So just come. Also butt scratchers, but leaning against the wall, pull your feet up and lower them slow. Don't just let them go thump, thump, because you're not training that response, you're training for specifics. If you guys want, I can email this all to you so you can click through it.
Yeah.
That way.
That'd be great.
Yeah. Another good exercise if you're at your desk, soleus exercise. So just doing that hourly helps circulation. I always say do those on the airplane, those sorts of things to prevent circulatory problems. Soleus raises. So he's doing an isometric one, but just having the balance to do that and raise up on your toes. That's going to hit that lower leg muscle. That might be a tough spot, so you might not be able to get down into a deep squat, but just doing it at the level of the squat that you can handle. I've kind of become a fan of a lot of these lower, you'll notice that I'm kind of a fan of the lower leg exercises because I had the unfortunate incident of tearing my Achilles, so I've had to go through a lot of these things. It was two plus years ago, but I kind of saw how hard it was to get that strength back, and a lot of these are things that I use as often as I can. I'll do 20, 30 of them, then do the other, and then come back and hit them a second time, third time. So this is just a bent over calf raise, so he's getting a fuller range at the ankle. And it's an FHL, that's flexor hallucis longus. So that's a muscle that goes to the flexor of your toe. So it's a nice articulation. So they're coming up on the toes and then lowering slowly.
So are these exercises you should do all the time, or exercises you should do if you've got knee issues?
So these are... Yeah, I kind of went a little disconnect here. These are just exercises that are a little bit off the grid, like maybe not so common. I would do a lot of these for knee pain, but again, it depends. Like there's some things where I'd be like, no, you don't need to do that one, but you should do this one. This was a Patrick step, pretty highly functional. It's basically controlling yourself off of a step. So if going downstairs gives you a lot of knee pain on a normal size step, we're reducing the step size. We're meeting you where you can successfully perform and then have you control lower, and it's really just tapping the heel of the other side, and then you can build up the step height. You can change the speeds. This is a Spanish squat. So he's going to get stability from the exercise band, and he's going to sit back that way. So it's a good one to really work the patellar tendons. Again, someone that might not be able to squat but wants to get back to squatting, that's kind of an intermediate one that we might take them towards. This one is just called a forward T or a single leg deadlift. Real good balance exercise. You might want to do it hanging on for maybe there we go. So it's real interesting to see people initially start this one. They're all over the place, and then you do it for a few days, few weeks, and they get a lot better with their balance. So it's working your glute, but it's also working the heck out of your ankle to try to keep stability. And then hip thruster, kind of an in vogue exercise in gyms. Seeing this one more, it's kind of the exercise that's going to build up your posterior, your glutes. There's right and wrong ways to do it. The key takeaways here is, you get kind of a little bit beyond a 90-degree angle of your hips. You position the bar there. A lot of times people will pad the bar because it's kind of uncomfortable. And you keep your head up and you're looking in that direction. So that's proper form. if you hinge back like he shows you there, you're kind of defeating the focus on your glutes. So it's as if you have a tail and you're tucking between your legs. And then the last slide. There you go. Sorry. These are tough. These are tougher, but you can scale them. If you can kneel, you do a lean back. You don't have to lean back far, but you just keep a connection between your shoulder, hip, and knee, so draw a straight line there, and you're leaning back. If you get really good at it, you can get really deep. But a real good quad builder. This exercise, Russian hamstrings, kind of for the opposite muscle group. So for the hamstrings, you're going to lock in your heels, either have a partner hold them or get them under something immovable. And again, you're going to keep a straight line. This one's tough, so put a pad underneath there. And you're just going to lower down to a push-up and kind of catch yourself. So if someone wants to do this one but can't, we might put a big wedge up here so that they hit the end range earlier. So again, that one might be somewhat good. It doesn't have a lot of degenerative changes there. Vertical knee raises. And all sorts of different permutations there. Or jumping upstream a little bit further away from the knee, but you can modify this one. You can do straight legs. You can do alternating legs. You can do hanging from a bar overhead, do with the knee raises. Or you can, if you get really advanced, you can try to bring the toes up toward the bar. Hip flexors. I would say this one's an undertrained muscle group in the gym and in general. I think what you saw there was about the extent. So sprinters are pretty powerful in these muscles, and a lot of track athletes are trying to pull up hip strength. So it's basically that pulling motion. So here's a couple of different ways of doing that. You lay your band back, put the band in between. So she's isometrically contracting this hip flexor while she's extending out the other leg. Kind of a good combo exercise because you're getting core there too. And then a psoas march. I've seen this one done a couple different ways. So banded, hanging on against the wall. So again, you can vary speed. You can do it slow. You can do real light resistance. You can do no resistance. You can try to contract the core there. The other way I've seen it done is feet on the wall and hands on the ground. That's a different sort of style, and it's kind of for the crazy folks at the gym that want to torture themselves. This is an L-sit, so very tough to do because a lot of demand on the core and a lot of demand on the hip flexor. The hip flexor is already shortened and you're asking it to really perform. So you can do it modified this way where you're just lifting your bottom. The other way I like to see it where it kind of targets your hip flexion more is if you're just sitting and then you're lifting your foot, like say over a cone. So one side, then the other side, and I'll work that out. This last one is just kind of that forward deadlift with a focus on hip rotation. So if that person's hip in the glute medius, so we call it a single leg airplane. If they're weak in that hip muscle group, we're just adding a plane of movement. So she's got to control that movement all with her left hip. If we want to strengthen the opposite group, we might torque her the opposite way. So where her hands were going this way, we might go that way on the same leg to try to get the internal rotators of the leg as well. So summary, those are the summary slides. Lower body strength matters. Bracing, taping, helpful but sometimes iffy. Avoid painful positions. Avoiding painful positions doesn't always work. Gently add to the demand to drive adaptive changes. Look up or downstream. Footwear changes make a difference. Exercise surface matters, so change it. Get on unstable surfaces. Get on grass if you're walking on grass. Get on slopes, sand. Endurance is critical. Landing softly is important. Use video if you're having a problem with a particular sport movement. Static stretching, maybe afterwards, but not before if you're trying to improve your power output. Squatting deeper than curl is okay. Strengthening combined with surgery, but you typically want to add the strengthening component. Radiographic findings don't always line up your final outcome. I've treated folks that have had stage 4 arthritis in their knee. I didn't think they were ever getting back to their activity, but they did. So it doesn't always line up. And then shameless plug, if you're struggling with an injury, connect with a therapist who can analyze your movement. So that's what we're here for. That's it in a nutshell. If you want to just drop me an email, if you want the presentation, I'll email to you, or you can email June.
You'll send it?
Yeah.
Send it.
Oh, thank you.
You'll send it in our email.
Yeah, good, thank you.
So, what questions do you have, if any? Happy to oblige. Did I go too technical or just right? Or
So how'd you tear yours?
I was playing volleyball and I did some movement I've done 1,000 times. I just stepped back, and on that step back, it went out and I hit the floor, and then I turned around to see what my teammate was running into me for. And she was nowhere. She was 10 feet back. I'm like, oh, that's not good. So that's bad. But yeah, and to this day, I felt just like an unwinding rope. That's what it felt like. It was just fast.
And this was your Achilles?
It was the Achilles, yeah. So fortunately, Dr. Verdon stitched me back up, and he said, "Who do you want to go to for therapy?" You know, with a smile, but he was kind of hanging out next door, so I figured being all stubborn. But yeah, it was a long process, and you know, a lot of times you'll hear after an injury, you know, you're going to get better in 6 months, and then you'll be about where you're at in a year. And I think that's true, but if you keep going in a year, I still got strength gains, and it's definitely something that's like reframe how long it can sometimes take. If you keep hammering away at it, you can get things back. But yeah, it was a tough process.
I have a quick question. I
Sure.
broke my femur when I was like 6 months old, and I know like my symmetry is off, but it's not off by that much. Like I don't notice it,
Mhm.
but will it affect me like when I'm older, or like any part, like hip or knee or?
Hard to say. If you break, I'll give you my old "it depends" kind of answer.
Okay.
But if you break a bone in the middle, you know, it depends on the nature. If you break it at a growth plate, you know, you were so young then, it probably won't, unless it affected your leg length or affected the joint somehow. If you break it in the middle, your body's pretty good at healing that up and coming through with, you know, as equally strong of a bone, if not more
One
so.
thing I noticed, I mean, like this calf, I think is like smaller, and like my foot's a little bit smaller.
Yeah.
It was this side, but like, I mean, it's not even like that noticeable like when I walk or anything. I'm just like, when you talk about the symmetry, like
Mhm.
the hips and stuff, I was just thinking like when I get older, like would something like that ever. So it depends.
Yeah, and so probably your best angle of defense against it would be if you are stronger on one side, weaker on the other.
I am.
We would probably say, well, let's try to strengthen up the weak side and bring it up to the level of the good side. You know, if there's a leg length discrepancy, put a small lift in there. You know, but usually don't like to throw external things at you. So,
Right.
but yeah, I would say try to bring up the weaker side. And,
Okay.
you know, it's not always a future destiny of pain if you do the right things early enough. So, good. You got a question?
I see a lot of older guys like me with knees and hips needing replaced. Is there anything we can do to strengthen to keep that from happening, or is it just their activity level? It's
Hard to say. Multifactorial, you know, lifestyle matters. High impact stuff matters. Traumatic, you know, accidents. I tend to see, this isn't a blanket statement, but I tend to see the folks that played some of those rigorous, you know, football in their 20s and late teens, they wind up a little bit more creaky. You know, some, I think diet plays a role in what we're taking in. Hydration, supplementation, general health activities matter. At what level, it's hard to say, but yeah, and a lot of times it's that weekend warrior posture that fades to an inactive state, and it's the inactivity that gets us. And so I think the mantra is put off knee replacement as long as you can, but you'll know when you need it. And you know, a lot of folks, they say, yeah, I put it off too long and I should have done this sooner. And then others, I think if they put in a little bit more time in the gym doing the right stuff, you know, maybe they buy a few years. So
Does heredity have anything to do with it?
yeah, a ton. I think if you have a predisposition to it, it's going to set the table. And then if you don't do anything about that table or, try to address it in the other ways, your incidence is going to be higher. But again, it's only so much genetic. There's a lot of environment that plays a role too.
Well, like you playing volleyball, did you stretch a lot or, like?
No, that's funny. So I try to think back. Did I overstretch that tendon and did I hose myself? I don't know. I tended to be one that stretched after. I like more of a dynamic warm up. Just try to get out, get things moving a little bit. And yeah, I wonder, maybe.
Well, I've always stretched that a lot, and I'm thinking, gosh, I wonder if I'm going to rip it sometimes because I really like to stretch it.
It's good. I mean, if you have a limited movement and your joints not functioning normally, yeah, you should probably try to get that motion back. But
I'm not limited. I don't know why I like to stretch it.
nothing necessarily wrong.
Just,
if you're not going into a competition,
yeah,
you're probably
no,
fine.
I just do it all day.
Yeah.
For some odd reason, I'm thinking maybe I'm damaging it.
Well, I'll tell you, like a couple of things that the conversation, I watched the previous presentations, and I was like, man, I kind of want to comment on nutrition, but then I kind of want to stay in my own lane. It is funny because there's lots of different opinions. So back when I tore my Achilles, not to talk about me, but it's a relevant story. I didn't change the way I ate, but my activity went down. So I put on 30 pounds like that because I just kept on eating. And said, all right, I gotta figure out what to do with this. And the strategy that worked for me is more carnivore. So I was downloading carbs before, and just I really didn't have, because I was so active, I really didn't have to pay attention to diet. And then I think the 40s hit, and then I think the 40s plus hit, and all of a sudden it's like, well, that's not working anymore. So I switched more towards there's a couple of people I follow online, but mainly meat-based, reduced carbs. I still do have some carbs here and there. Meat, fruit, honey, dairy, and that's my strategy. It worked. I feel good. So I listened to Dr. Williams, and her parting statement was "eat less cheese." And I'm like, oh my gosh, I'm in trouble. I'm gonna be.
She kind of pounded the cheese.
Yeah, I'm like, oh my gosh.
Eat less cheese. Eat less cheese.
And she's in wonderful shape, and she does what she does for a living, and I'm sure that strategy also works. But it's like, man, I really like my cheese, so I got to figure out how this works. I think for me, what I've experienced is it's hard to gorge on protein. You can only have so much, and then it's like, done. Same with fat. I don't limit fat. If it's a fatty meat, if it's an 80-20, so what? I don't limit it because it fills you up. Carbs don't. It's like I down a bag of chips, and I'm like, okay,
Where's the next bag?
Yeah. So, not to say that, hey, sometimes like somebody's on a diet that's successful, that's all they talk about. Man, you should go carnivore.
The king.
Yeah. But that's my experience. It worked. It dropped me back down to my pre-tear weight, but it was, I had to change some things. And really, sugar's addictive. Sugar's not addictive. So that's my take. All right.
Do they still do functional fitness evaluations?
So
It's like,
they do one called a functional capacity evaluation. So like an injured worker, if someone's off the job, a workman's comp injury, and they have a job description and there's a physicality piece to it. We have a therapist in Jefferson who will do an FCE who basically assesses your response, like a 2 to 4 hour test, and then they'll give you guidelines, like this is your lifting category, frequent, constant, intermittent, and these do like what's safe for you, and this would be out of your zone, and then you match that to the job description. So that's what is that what you're talking about?
well, that's good to know too, but like if somebody starts to say, I'm walking slower because I'm afraid to fall,
Okay.
and they don't have an answer, or you kind of start to, a lot of
Yeah.
people I work with and see are already leaning in a different way, and it's like, is that a muscle weakness? Is it not a moving? And as they're talking, they're like, no, I can't do this because it hurts too much or whatever. And I thought at one time there was something that, because I tried to say, this could be a muscle thing, but it could be a mechanical thing. And I said, we need to find out which way it is first. But I don't know, it's not like they had a fall and they're in the hospital and they can't walk because they were so sick. I didn't know if there was an in-between.
Yeah, so if there's a functional limitation, typically a therapist can look at it. We can evaluate for it. It would, traditionally it would be a conversation with your doctor and, hey, I'm losing function. I think talking to a therapist, and I'll write you a script. And typically we're going to tie it to a functional loss, like I'm not able to get up and down the stairs, or knee pain, or some sort of pain that's limiting them. And yeah, that would typically qualify through your typical insurance. Now, PT has direct access. You can come to a PT directly now. The state no longer requires a referral. The challenge there is a lot of insurances still require the referral. So what we end up doing with that, if someone does want to come in to see us, we'll typically see them if it's an appropriate condition, and or at least talk to them. And then we'll convert that. We'll say, hey, who's your primary doc? We'll send the note to the primary doc and say, hey, this just an FYI. They sign it. That becomes an order. So that would be the workaround. So yeah, if you're seeing folks that are limited like that.
I don't know if they come see you, but I refer you.
Yeah, no.
I refer therapy often.
Happy to do it. And
It's hard if you haven't been working out and everybody watches a TV or a video and they don't think about, I can't do 10,000 steps today because I've only done 2,000 steps yesterday.
Well, there's so much information on I've pulled a lot of those videos. I should cite all the videos that I did. But yeah, there's a lot of information out there. There's a few guys, the Squat University guy, he's really good. I use his stuff, or I watch his stuff. Paul Saladino, he's the Carnivore MD 2.0. I watch his stuff a lot. There's another one, James Nicolantonio. I'll just produce different. Carnivore MD 2.0, I think. So Paul Saladino is his name, but he's a little rough around the edges. He's pretty deep into the carnivore type stuff. Whereas like eating stuff that I can't bring myself to eat some of the stuff that you bring. But I do think there's something to be said for that strategy, and then also something to be said for the center of the grocery store being mostly poison, mostly garbage. So,
They're moving the garbage to the end cap.
Are they?
Every time I go through the perimeter, and I'm like, I can't tell you to just go around the perimeter because there's my chips. I might want the other bag in the other row, but it's sitting right there.
Right. I think Dr. Williams commented a little bit on it. I think it was Ariana Gathered. Something to do with seed oils. I got those out of my diet. I feel a hell of a lot better. So seed oils. Vegetable oil, canola oil, corn oil. It's cooked with everything. So dive into the research. I won't tell you because that would be a whole other topic, and you'd be more with your background than me to talk about that. But I've carved those out. They're inflammatory. They're, at least in my opinion, they're inflammatory, and they're in everything, absolutely everything. So just pause.
All right. Well, thank you.
You're welcome.
Very much.
Thank you very much.